Welcome to my beginner's guide for making a diagnosis. I am Mark Otan, an emergency physician and graduate of the class of 2006. What I will be showing you in this presentation is a framework for making a diagnosis that is not the traditional teaching of how to make a diagnosis, but one which I developed through my training, research, and practice. I have used this basic framework when teaching students and junior residents over the years with pretty good success. I have found that this framework is a good starting point, a good foundation for more advanced skills in making a diagnosis. The framework we will be discussing is for coming up with a diagnosis in an undifferentiated patient. That is, a patient who does not yet have a diagnosis, a patient who probably you only have the chief complaint for. The undifferentiated patient is a common occurrence in medicine. These types of patients come in two basic scenarios. One, a patient who is new to you, or two, an old patient with a new complaint. Achieving a diagnosis, or at least narrowing down the list of potential diagnoses to just a few, is a skill that all med students should start to develop, even if they are only just starting their third year. Knowledge of disease patterns is key to starting to organize yourself. As a med student, you may think that you do not have much medical knowledge, but you probably have much more than you give yourself credit for. Regardless, do the best you can with what you have. Start off by determining what the patient's primary symptom is. In most situations, before you go into the exam room, you will have at least a general idea of the main symptom, whether it be shortness of breath, fever, dizziness, etc. Next, ask yourself what diseases can cause this symptom, and what pattern of findings do those diseases have. Once you have the disease patterns in mind, actively seek out these patterns. Do not passively let the pattern bubble to the surface. Actively look for specific findings with direct yes and no questions. Once you have a good handle on the patterns you're looking for, you will match disease patterns with the symptoms the patient actually has. Basically, you are pattern matching. Start actively looking for 2 or 3 diagnoses to start. Some symptoms will have many possible causes, so start with 2 or 3 in the beginning. As you gain more experience, you can keep more in mind. Pick these diagnoses before you evaluate the patient in detail. This is a reasonable number to keep actively in your mind while evaluating the patient. As I discussed before, ask the patient about the presence or absence of specific symptoms. How would you choose these 2 or 3 diagnoses? Pick from what is common and what is serious. For example, for shortness of breath, you could choose the following 2 causes of shortness of breath: anxiety, a fairly common disease, and pulmonary embolism, a very serious disease. At this point, you will see how well the patient's pattern of findings fits the 2 or 3 diagnoses you have chosen. If the pattern of the diagnosis clearly does not match what the patient's pattern is, then take that diagnosis off the list. If the patterns of a diagnosis fit well together with a patient's pattern, then you have the diagnosis most likely. Keep in mind that in practice, the disease patterns will fit to varying degrees. Look for additional disease patterns later, only after you have found that the initial 2 or 3 diagnoses are not a good match. Only then should you seek out other patterns. Many times, a clear pattern for a diagnosis emerges at this point, because you have probed for enough information for that pattern to become apparent and recognizable. After this initial pattern matching, consider what tests, if any, you need to differentiate further between any remaining diagnoses on your list. After a thorough exploration, more than one diagnosis may still be on the list. Think of tests in this way. Tests fill in gaps that the history and physical exam cannot fill by themselves. After considering what testing you may need, you are ready to present to your resident or your attending. You may still have 2 or 3 diagnoses to consider as the cause of your patient's symptoms. And that's okay. Just be sure that the presentation reflects the work you've already put in at this point. Let's have a concrete example. The theoretical framework is all fine and good, but to really see how this works, you need to have a fleshed out example. For this example, let's take a hypothetical 55-year-old female who presents with a cough. For a cough, we can make a list of 3 initial diagnoses: pneumonia, congestive heart failure, and lung cancer. For each of the 3 diagnoses on our list, we can make a list of the pattern of findings. Take a moment and skim through the list of findings for each diagnosis. Note that these lists are not exhaustive, but are more focused on a handful of key findings. Next, we match the patient's findings with the disease patterns we've selected. The key thing with this is to seek out the patterns explicitly before you move on to a new set of diagnoses. For example, when evaluating for pneumonia, ask specifically about fever, purulent sputum, shortness of breath, and pleuritic chest pain. Do likewise with the other remaining diseases until you have gone through all of the potential findings. We can then see which diagnosis matches the patient's pattern the best. In this case, it seems to be pneumonia, but there is still some overlap with lung cancer and congestive heart failure. This approach may sound daunting at first, but after trying this with just a handful of patients, most students tend to get the hang of it pretty quickly. In the next step, consider what tests can differentiate the diagnosis further. How about an X-ray, an ultrasound? How about a CAT scan? Consider the strengths and limitations of each test when deciding. Going into detail about this right now is outside the scope of this talk. Regardless, at this point, you should be able to present to your resident or your attending. To summarize, use the following framework when approaching an undifferentiated patient. 1. Actively seek specific disease patterns. 2. See how poorly or well the disease pattern of the patient in front of you fits the diseases you decided to look for. 3. Add new diseases if the initial patterns fit poorly. 4. Use testing to fill in the gaps of information that the history and physical cannot fill. This quick explanation of this framework is by no means an exhaustive explanation, nor the only way to go about evaluating the undifferentiated patient. However, it is enough to get you started and gives you the foundation to build upon for more advanced skills as you progress in your career.